Sure. So thank you, organizing committee ASSI, for giving me this opportunity to share my experience on dual spine endoscopic decompression in lumbar canal stenosis. So my disclosures. So among posterior endoscopic spine systems, we have nowadays dry endoscopic techniques available and saline endoscopic techniques available. So among dry endoscopy, we have Destendu technique, we have arthrospine, and we have EasyGo. Destendu technique relies on a conventional dissection, whereas EasyGo and arthrospine technique relies on a muscle dilatation technique. Among spine endoscopic techniques, we have full endoscopic techniques, UBE. Then we have recently arthrospine UBE system, which is our Indian innovation. Then we have UUE also, unilateral, uniportal endoscopic techniques. So now talking about some nuisances which are there in a dry technique. I have been a Destendu user since 2002. So there is an issue of tissue creep, swelling of scope tip when working in depth. Scope doesn't advance beyond tube, and there are fusion limitations also. Among wet or PSLD or UBE, I'll talk later. Narrow field of view instruments through scope channel, very fine instruments, risk of breakage is very, very high. Fusion limitations again, and cost of expandable cages is really needs a consideration. So biportal endoscopy, UBE or UUE, it's a uniportal also nowadays surgeons are doing. So there is an issue of orientation, difficult triangulation, more radiation exposure. So we worked and thought, why not to strike a balance among both the techniques, where we are using best of dry endoscopy also and saline endoscopy also. So question comes ki why dual spine endoscopy? So as I mentioned, in dry technique, there is a repeated staining of scope tip while working closer to dura, and repeated staining frustrates to the surgeon and adds to the more operating time. As you will see here in a dry technique, see there is a swelling of the scope. And if we talk about saline, there's no issue of swelling, but fluid complications also in dual spine endoscopy are reduced. But in a complete saline endoscopy, the huge quantity of saline is used, which can add to and cause complications also. I'll not talk about the fluid-related complications. That is a different topic altogether. But surely there is a more clear tissue differentiation as far as saline endoscopy is concerned. You can clearly see how you are working so very close to the neural structures, and you are able to see the working tip of the instrument. So chances of neural injury are also minimized. So talking about physics, when you are working dry mode, it's a classical posterior interlaminar concept. Anatomy and appearance is like Distendu, microtubular, EasyGo. And especially for surgeons who are conversant with endospine or microscopic techniques, so easy for them to switch over to this technique. And when you switch over to a saline mode, it is recommended when working closer to the dura, as repeated scope swelling can be frustrating and it can be avoided once you switch over to saline mode. Continuous saline inflow and outflow to ensure constant hydrostatic pressure at surgical target. A clear and enhanced field of view is there. For surgeons familiar with arthroscopy or PSLD, again, this is more easy to learn. And as you can see here in this video, that how fluid is freely coming out through a working port, and it is a gravity aided fluid which is going inside and coming out freely from a working port. As you can see here, The technique is arthrospine tube lands over an interlaminar window. This is just to share our innovation or our Indian triangulation technique to shorten the learning curve of UB. Then we use a single rod through an additional port, and then this rod is advanced towards the arthrospine tube. And as you can see here, small video that how the single rod touches the arthrospine tube and there is a sound. So we call it as a sounding technique. And then surgeon slides the arthroscopic sheath or endoscopic sheath over the single rod. And then scope is fitted over the sheath, and surgeon removes the arthrospine tube and starts working with the instruments as a freehand technique. So the tube port becomes here a working port, and it's a freehand. There's no tube now. The surgeon has more liberty and freedom. Applications. These dual spine endoscopic techniques can be used in cervical, thoracic, or lumbar regions, even in spinal canal stenosis, and some other extended indications also there where this technique is useful. And very simple instrumentation. Here you can see some of the instruments are same which we use in conventional surgery. And initial steps is, as far as anesthesia is concerned, it can be done under local, regional, or general anesthesia, but my preferred choice is regional and general anesthesia. Patient is prone on bolsters with the lumbar lordosis neutral. Surgeon usually stands and approaches from the symptomatic side. So 18G spinal needle for level localization is done under C-arm guidance. Lateral view is taken. Then 10 millimeter skin and facial incision. Then 5 millimeter away from the spinous process is used. Passage of serial 5 millimeter and 10 millimeter corpse tip dilators is used. Docking over the spinal laminar junction. These are docked over spinal laminar junction. Then passage of tube over 10 millimeter dilator and connect scope sheath and start working. Now, this is a case demonstration, a lumbar canal stenosis, L4-5 stenosis, 48 years old female, severe neurological claudication, radiology, MRI, LS spine revealed severe LCS L4-5. On access, there was no instability. So, as you can see, patient is prone, and I am using a number 11 knife to give a about 10 millimeter skin and facial incision. Then I am using a dilator, 5 millimeter dilator, which docks over spino-laminar junction, and gradually you try to erase the tissue from the lamina and the interlaminar window. Then you use a 10 millimeter dilator. And then this tube, working arthrospine tube, is slit over the dilator, and dilators, you continuously feel the tactile feeling of your tube is hitting the bony lamina, and then dilators are withdrawn, and you can have a then endoscopic view of the inside structures like lamina is there. This is a right-sided approach. So 12 o'clock is a spinous process, 3 o'clock is my superior lamina, facet is at 6 o'clock position, and 9 o'clock position is the caudal side. And then you can use a burr also to burr the thick lamina, and that makes surgeon's job easier. As you're seeing here, we are using a diamond burr. This is the same arthroscopic burr which we are using in knee arthroscopy. And then you can see that after burring, the surgeon is able to see the detached flavum. Then we try to put a small patty over the dura to create a space between dura and the ligamentum flavum. And then we bit by bit with the Carrison punch, we remove a flavum. As you're seeing here now, you can have a glimpse of dura. Dura is clearly visible. You can see the probably my nerve root retractor is in the axilla, and there is a exiting nerve root. Now, once we are close to neural structures, after exposing the flavum, we switch over to a saline mode. So that's why we call it dual spine endoscopy. Now we are trying to do a ipsilateral decompression. As you can see, bit by bit, we are moving the thick flavor. And as you keep on decompressing, you get the exiting nerve root, and disc space comes into your view. You can probe the disc space, and then you start working on the opposite side and try to remove the flavum. Maybe part of the facet, undercutting facet, is done to expose the open the recess. And here we have removed the opposite side flavum, and we are able to probe the nerve root. There is a capacious recess opening there. And then finally you see nice ipsilateral nerve root going into the foramina, adequately decompressed foramina. There is a disc which is well contained, so there is no need to do any discectomy here. And this is you can probe even axilla also. And then you go to contralateral side, you can see midline neural decompression, thecal sac is nicely decompressed. And that is the end point of your decompression. So since 2002, I started my journey with a dry endoscopy. And 2019 onwards, we have been using a dual spine endoscopic technique where I switch over to saline when I close to my surgical target, which adds to comfort. So I see we are able to use advantages of both dry and saline endoscopy. And what I have observed is in saline endoscopy, if there is an inadvertent dural injury, so you can switch over to dry endoscopy and do the intervention. Similarly, if there is excessive bleeding during saline endoscopy, I have experienced that I switch over to dry endoscopy and able to control bleeding more confidently. And we do have our shares of complications. This is a complication related to my whole series, not only to lumbar canal stenosis. And then, so to summarize, dual spine endoscopy by arthrospine UV technique can be used in dry PSLD, UV or UUE mode. Adequate midline and bilateral recess decompression can be achieved in any area of spine. Innovative sounding technique helps minimize UV learning curve, radiation, and excess tissue RF ablation. And it is an indigenous design, thus it is a very, very cost effective. Thank you very much.